Hi everybody, welcome to our webinar. I was going to say this evening, it's this evening for me, it's daytime for lots of people. The webinar is entitled Suicide Research Priorities During the COVID-19 Pandemic. And we have, I can see 123 participants online at the moment, but I know we have nearly 500 people registered. So I think...
24 participantes agora, mas temos quase 500 participantes.
So my name's Jane Purkis. I'm the Director of the Centre for Mental Health at the University of Melbourne, and I'm also one of the Vice Presidents of the International Association for Suicide Prevention, and I'm the Editor-in-Chief of Crisis. So the webinar itself is brought to you by a new international collaboration of researchers working in this field. We've got a slightly long name, which is the International COVID-19 Suicide Prevention Research Collaboration. So the webinar is brought to you by the collaboration and also by the International Association for Suicide Prevention. So just a couple of housekeeping things to start with. The session is being recorded. I can see a flashing red light in the corner of my screen. And so the recording will be available to all those who've registered in the near future. There'll be an email that comes through letting you know how to access that. And the other thing I just wanted to mention was that if anyone has any need to make use of the self-care notes that were provided in your registration confirmation, please do that too. You know, talking about suicide and suicide prevention can sometimes be quite confronting, so do just take a quick glance at those self-care notes if you need to. So we've got 4 speakers today. David Gunnell, Thomas Niederkrotenthaler, Keith Horton and Ella Ahrensman. I'll introduce each of them in turn before they speak. We've also got Wendy Cliff, who I can see a still image of on the corner of my screen as well, from the International Association for Suicide Prevention, who is helping us with technical support from behind the curtains, as Ella Ahrensman would say. So during the webinar, we're hoping that you'll learn some things about the collaboration itself and the work that we've been doing. The speakers will each talk about some of the things that we've been doing and thinking about. But I did just want to mention one of the things that we've done before we start, which is that we've prepared an open access editorial that's been published in Crisis, the journal that I edit, which is, as I said, it's open access and it's available online now. I think Wendy is going to put the URL for that in the chat if you want to access that editorial. So each of our speakers will talk for about 5 minutes about some of the aspects that we've covered in the editorial and some other things as well. And then we'll have an opportunity for a panel discussion and some Q&A. There's a Q&A button at the bottom of your screen. So if you've got questions that come to you as people are speaking, feel free to jot down a question. We'll do our best to perhaps bring together some common themes in the questions and give the speakers a chance to answer them. We'll see how many we can get through. If you want to ask questions anonymously, there is an anonymous box you can tick in the Q&A. So do that if you're not keen to reveal who it is that's asking the question. And we're also going to be running a few polls during the session, just quick questions that people can provide answers to. So, in fact, we might start with one now. So
nós vamos começar com agora.
First poll. So, on your screen, you should be able to see the question.
Primeiro questionário.
Will increase during the pandemic, and your answer.
Você acha que o suicídio vai aumentar durante a pandemia?
So we'll just put that up for a little while. I'm seeing a flashing thing saying the host and panelists cannot vote. So that's just a taster for how the polls work. We might release the results of the poll, Wendy. Have you ever been to such an exciting webinar? Okay, so The majority of people, 3/4 of the audience, of whom there are now 177 participants, think that suicide will increase during the pandemic. A much smaller proportion say no, 9% say no, and 17% say don't know. So that's quite interesting. Thanks, Wendy. So we might move on to, I'm not sure whether I can close that, Wendy, or I can close it. Without further ado, we might move on to our presentations then. So I'd like to introduce our first speaker, David Gunnell, Professor David Gunnell from the University of Bristol, who'll be well known to many of you, he's going to talk as our first speaker about the International COVID-19 Suicide Prevention Research Collaboration. So thanks, David. David, I think you're on mute.
Okay, thank you. So good morning, good afternoon, or good evening to everybody wherever in the world you are right now, and many thanks for joining us, and thanks for that introduction, Jane. Today I'm going to give a quick introduction to the International COVID-19 Suicide Prevention Research Collaboration. Sorry, it's a bit of a mouthful, isn't it? Before handing over to my fellow speakers. So the last 7 months have been an unprecedented time for many of our lives. The COVID-19 pandemic has infected millions of people worldwide, and over 600,000 people are known to have died. In the suicide prevention research community, of course, we're concerned about the impact of the pandemic, the public health measures taken to mitigate the spread of the pandemic, and the effects of bereavement and the virus itself on suicide risk. And there has been lots of speculation in the press about these possible impacts, and it was interesting to see the poll results just now. I think on balance, most newspaper reporting has been relatively alarmist, and I've got a couple of examples of newspaper headlines from different countries in the world at the top right of this slide. Suicide attempts might soar amongst lonely elderly during lockdown. A year's worth of suicide attempts in the last 4 weeks, according to a Californian doctor. Interestingly, a story that was later refuted in a subsequent article. But the key, but we really don't know. And the key issues for us are a desire to know what the impact of COVID-19 will be on population mental health and suicide rates, so we can bring clarity to these concerns and we can inform appropriate prevention strategies. And secondly, what can we in the suicide prevention research community do to reduce the impact of the pandemic on suicide deaths? The research literature is really sparse on this issue. We cannot really learn from previous pandemics. One of the very few papers that reports on the impact of suicide of a previous pandemic was one published by Ira Wasserman, looking at the impact of the Spanish flu pandemic in the United States between 1918 and 1920. And this slide here shows a summary of findings from that study. The chart shows trends in overall mortality and suicide mortality between 1910 and 1920. And in the study, he was looking at a number of different possible influences on suicide rates, of which the Spanish flu pandemic was just one. It's important to note when looking at this slide of trends in suicide rates, and the suicide rates are the line with the black crosses on it, that the suicide rates are rates per million, whereas the overall mortality rates are rates per 10,000. So whilst it appears there's a similarity between overall mortality rates and suicide rates, in fact, that's because the scales are quite different. I think the most striking thing you see on this slide is that those two peaks in overall mortality, one towards the end of 1918 and a second slightly smaller peak between 1919 and 1920. And those are the periods of time when the Spanish flu pandemic were at its peak. If you then turn to look at the line for suicide rates, you see, if anything, in the years leading up to the pandemic, suicide rates were going down. And there's really no clear evidence from looking at the line for suicide rates of a rise in suicide at the time of the pandemic. Careful statistical analysis that took account of changes in alcohol consumption, media reporting, the impacts of World War I, indicated weak statistical evidence of a small rise in suicide, though, following the period of the pandemic. So there was some evidence of a small rise in suicide rates. The only other good quality evidence we've got really comes from the impact of, looking at the impact of the SARS pandemic in Hong Kong in 2003, work by Paul Yip and colleagues in Hong Kong. And there was evidence from their analysis that suicide rates in the elderly rose for a short period of time at the time of the SARS pandemic in 2003. So, as a group, researchers from a number of countries got together. The collaboration now consists of people from 29 countries, 10 LAMICs, so the countries involved so far listed at the top right of this slide, to think through what the key issues were for the suicide prevention community. And I won't go through the slide in detail, but it summarises the findings from our Lancet Psychiatry commentary paper published now about 3 months ago. And we sought to lay out what were the likely concerns in relation to suicide posed and threats posed by the COVID-19 pandemic. And we highlighted some of the clinical issues, concerns about new methods of delivering care to people during the pandemic, concerns about how best to assess people who were suicidal, and some of the public health concerns, such as concerns about media reporting, possible rises in domestic abuse as a result of lockdown, rises in alcohol misuse, and a series of other factors. But I'd point you to the link to that article to look at the details of what we found. So, in the absence of good quality evidence and a real concern about the possibility of an impact on suicide and suicidal behaviour, a group of us came together. Our aim as a collaboration was to enhance good quality collaborative research on the prevention and management of suicide and suicidal behaviours in relation to the COVID-19 pandemic. And we have undertaken a series of initiatives in the early weeks of this collaboration. We've established a suicide research study register. The link is on this slide, and we'd encourage anyone involved with suicide research to put details of their study on this register. It will facilitate collaboration. It will provide an opportunity for people to see what other people are doing. Some of the early career researchers in our group came together to create a toolkit of possible questions to use in questionnaire studies related to COVID-19 and suicide prevention. And again, the links on the site. I particularly thank Dean Knight and Olivia Kirtley for their work on that. I've flagged the Lancet Psychiatry commentary already. And our most recent initiative has been around this crisis editorial that Jane's already mentioned and that Thomas Needham-Krottenthaler, our next speaker, led. And so at this point, I'll hand over to Thomas to talk about and introduce that editorial. Thank you.
Thank you, David. That was a great overview of not only the reason why the collaboration got together, because of the concern that suicide rates might rise, but also the fact that we just don't know, and that we need to do some good and fairly speedy research to find out. But also a great overview of what the collaboration is currently looking like and what it's trying to do. So thank you for that. So I'll move straight to our next speaker, who I can see in the corner of my screen, who again is someone who probably needs no introduction, Thomas Needham-Krottenthaler from the Medical University of Vienna. And Thomas is going to talk to us about some of the considerations, the research considerations that we might want to have at the front of our minds if we're doing COVID-related suicide research. So thank you, Thomas.
Thank you, Jane, for this introduction. So as David has highlighted already, COVID-19 is really a very unique challenge to suicide research and its prevention. I've selected a few crucial considerations from the research perspective for this webinar, and there's certainly much more to say, and you find a more complete list in table 1 of the editorial. Importantly, nearly all of the available research at this point is from high-income countries. So that's really a major problem because these findings might not generalize to low and middle-income settings. For example, and there are many others, social distancing might have a totally different impact on individuals in large households, as they are frequent in lower income countries, as compared to single households, which are very frequent in high income countries. In order to deal with the low quality of mortality and hospitalization data on suicidal behavior, which is a problem across the globe, but particularly also in low and middle income countries, it would be absolutely necessary to have further sentinel sites in addition to those that already exist, for example, in Sri Lanka or China. So that would really be helpful from the research perspective. A different issue is that the emergency response to COVID-19 has resulted in far-reaching adaptations in the delivery of care to suicidal individuals. Mass rollouts of remote consultations, digital interventions, and new care pathways, all of them still require evaluation and subsequent adaptations of services. Here, it seems necessary that we implement real-time evaluation methods, and there are some creative adaptations necessary to classic evaluation designs in order to provide robust results. In general, research on the implication of the pandemic for suicide and its prevention really call for a truly interdisciplinary, multidisciplinary approach. Only a multidisciplinary approach can capture social, cultural, psychological, biological, medical, and public health aspects of the pandemic, all of which appear essential to mitigate the effects of COVID-19 on suicide. A practical issue here is that some research settings which are normally available are not available now. For example, schools and universities are closed during lockdowns, and participants now need to be recruited in alternative settings, for example, online. Further, time pressure and social distancing might result in individuals with personal experiences of suicide or suicidal ideation not being involved in such research. It is absolutely crucial here to note that researchers have to include individuals with personal experience at all stages of the research process, particularly now at this time of increased vulnerability. On a more general level, research on COVID-19 has not always complied with ethical standards. Many of you might have heard of two highly influential papers on hydroxychloroquine, which had to be retracted due to severe shortcomings. The necessity to mobilize research resources and publish them quickly certainly plays a role in such incidents. There's also an increasing number of researchers from other fields outside of suicidology who are now shaping discussions on suicide. Adequate training on how to conduct suicide research and sharing of relevant safety protocols, research protocols, all of that is crucial to ensure that standards are met. There are also, of course, implications for the safety of research participants and researchers. Safety protocols that reduce the risk of infection in the workplace are essential, and managers of research teams need to be aware of the psychological burden resulting from home office and social distancing. Further considerable burden is put on healthcare workers. There is specific psychological guidance available from, for example, WHO, to address some of these specific areas of concern. Let me continue with a few words on the media, and I'd like to kick this off with a poll question. So the question is, Have you seen sensationalist media coverage on suicide in relation to COVID-19 in your country? Please provide your answers. I will inform you about the results in a few seconds. So generally, it is important that media guidelines should be used and widely distributed to media to reduce the risk of imitation effects and also to reduce the risk of stigmatization. Here it is important that we have now also COVID-19 specific suicide reporting guidelines available, and you can find them in the ISP COVID-19 Resource Center. Of particular concern are media reports on suicide that use COVID-19 as a very simple explanation for suicide. The term COVID-19 suicide, for example, which has been increasingly used even by some of the experts in suicide research, should not be used because it is a gross simplification, and the specific circumstances of a suicide are, of course, typically not verified in media reports. Okay, and I'm having the findings here from our poll. So 60% say they have seen sensationalist media coverage of suicide in their country related to COVID-19. So that's quite a number, and it shows that this is a really important area of concern. I'm just now having some difficulty with forwarding to my final slide. But I will just give you that information verbally. So there's a second aspect of the media strategy, and that is that research findings nowadays often warrant rapid publication. The open science framework and fast-track peer review options appear to be viable options in this regard. It is, however, very important for authors to set up a clear media communication strategy proactively before the release of any findings. The strategy needs to address how specific findings may be picked up in the media, particularly if the findings are bold and preliminary. It is essential that press releases highlight that preliminary status. So these are a few of the aspects. There's certainly much more to say. Let me end with a big thank you to every one of you who is doing suicide research during these difficult times. And I hope that our resource and our collaboration will contribute to reducing the risk of seeing an increase in suicides during and in the aftermath of the pandemic. Thank you.
Thank you very much, Thomas. Especially, I think, for your words of wisdom about media reporting, and particularly, I think, that your nod to the fact that as researchers, we have a responsibility to make sure that what we say to the media is appropriate in these times, particularly. But also, thank you for highlighting some of the other issues that we need to consider if we're doing research in this area at this time. So thank you. So our next speaker, again, is someone who will be very well known to most of you, Professor Keith Horton from the University of Oxford. And Keith is going to talk about some specific research questions that seem to be bubbling away, being of interest in the current time. Thank you, Keith.
Well, there's clearly a need for good quality research in relation to the COVID-19 pandemic and suicidal behavior. I'm going to consider some examples of research questions. A fuller list of these is provided in the crisis editorial. And I'm also going to mention some examples that are already listed on the research register of the collaboration. But I would also emphasize that we need more research questions. I'm sure there's a lot more research going on than is listed there, so please do register studies because it will be helpful for other people to see what is going on, and will allow sharing of methodologies. So I'm going to consider briefly, firstly, studies of the impact of the pandemic on suicidal behavior. Secondly, population factors that are likely to influence the impact. And then finally, and perhaps most importantly, prevention and treatment of suicidal behavior. So can I have the next slide, please? So here are examples of some of the questions in relation to the impact of the pandemic on suicidal behavior. Firstly, what are the impacts, both short-term and longer term? For example, interestingly, we've seen a decline in self-harm presentations to hospitals in the UK in the early phase of the pandemic. So it isn't absolutely necessary that there will be an increase. There are examples in the research register from Sri Lanka, the UK, and Canada focused on trends in self-harm and attempted suicide. And also there's an IASP group that is led by, partly by Jane Perkis, which is trying to bring together international data on suicides. And also there's a UK initiative looking at suicides in children and adolescents. A very important aspect to recognize, as Thomas mentioned, is that the impacts of the pandemic on suicidal behavior may vary greatly between countries, and especially between lower income, middle income, and higher income settings. And they're also the impacts are likely to vary according to what were the existing levels of suicidal behavior prior to the pandemic, and of course the extent of the COVID-19 disease. The impacts may vary according to population subgroups, obviously gender, age, socioeconomic status, and especially in people with mental health problems. And finally, there may be subgroups that are particularly affected by the pandemic in terms of risk of suicidal behavior. And I'd highlight here, of course, those who've been infected with COVID-19, and particularly those who've had severe infections. And secondly, frontline health and social care workers who may be subjected to particular stresses. If I could have the next slide, please. And then there may be population factors, well, I've already mentioned some, that may influence the impact of the pandemic on suicidal behavior. And these may be measures of, for example, general population levels of depression, anxiety, hopelessness. Alcohol use may be extremely important. Measures of loneliness, sense of entrapment, domestic violence, economic hardship. There are also important questions related to changes in access to suicide means, which may have occurred partly because of the pandemic, that may have important effects on suicidal behavior. And as examples, we know that in the USA, in the early stages of the pandemic, there was an enormous increase in purchasing of firearms. There may have been changes in the availability of pesticides in countries where these are used for suicidal behavior. There may be issues related to stockpiling of medication, particularly analgesics, that might influence suicidal behavior. And then in contrast, there may be reductions in certain suicide methods, and one example might be suicide involving railways, particularly as the levels of rail traffic have decreased. Thomas has highlighted the importance of how the media is reporting on COVID-related suicides. I won't say much about this, but just to add, one thing is about predictions by experts or so-called experts. We've had some examples of, I think, rather irresponsible predictions of massive increases in suicides that have got into the media, and we know that such reporting of this sort of information can potentially have effects on population levels of suicide. So I think this is very important. There are two studies on the research register, one from India and one from the UK, specifically focusing on how the media are reporting suicides. And then lastly, there are we know that the patterns and content of social media may give important clues on how the pandemic might be influencing suicidal behavior, thinking and behavior. And an international research group is already conducting a study on this, which is on the research register. And very impressively, they've already had a research publication come out. And then can I have the last slide, please? And then there is the most challenging, really, research area, which is that of prevention and treatment. How can we prevent suicidal behavior that may be related to the pandemic? And the important questions are, how might public health measures influence suicidal behavior, such as lockdown, physical distancing, and so on? And how does the public response to these, which may reflect confidence in governments, how might this influence suicidal behavior? And then there's the important question of how to address the problem of delivering care to people who aren't in contact with psychiatric services. And then how can we deliver care to known suicidal individuals who are afraid to leave their homes because of the pandemic, or, and perhaps more importantly, how can we deliver care when services may not be providing face-to-face care? And I would add here that in some work we're doing, we found that one of the reasons for people self-harming has been particularly their loss of face-to-face care, even though they may still have telephone or other online support. And then lastly, how are telephone crisis services being used for suicide prevention? Has their use increased, and are these helpful and effective? There are a few intervention studies on the research register, on the collaboration website, including, very impressively, a randomized controlled trial from Canada to assess the impact of email messages provided in addition to usual care for patients under the care of psychiatric services. So in conclusion, there's clearly major research challenges which will need different types of research approaches, both quantitative and qualitative research. And we very much hope that the research register on the collaboration website will steadily expand and provide opportunities for sharing of research methodologies and findings. So lastly, another poll question for you. Do you think self-harm will increase during the pandemic? Without wishing to influence your responses, I think it's really important that we don't necessarily assume that, and David's already touched on this, that suicidal behavior, including self-harm, will increase, but I will not try to influence your responses further.
Thank you very much.
The results.
Are you able to show us the results, Wendy? Oh, well done.
That's interesting. I'm very interested in the third of respondents don't know, and I think that's how I would respond.
I don't think you influenced anyone at all, Keith.
Sorry?
I'm sure you didn't influence that don't know bar there. Thank you very much, Keith. That was great. And I noticed that I've been monitoring some of the questions on the Q&A and also some of the questions that came in before the session. And I noticed that some of them align quite well with the kinds of questions you were posing, Keith. So you may get the chance in the panel session at the end to try to answer some of your own questions. So I can see the fabulous Professor Ella Arensman on the screen now. Ella is our next speaker. She's from the National Suicide Research Foundation and University College Cork, and she's going to talk to us about the collaboration and some of the organisations, partner organisations it's collaborating with. So thank you, Ella.
Yeah, thank you very much, Jane. And just on a practical note, since this webinar started, my line was interrupted 5 times. So keep fingers crossed that it won't happen now. First of all, it's amazingly encouraging to see the huge number of people attending today. I think it really underlines the importance of international collaboration in relation to suicide prevention and research during COVID-19. And David Gunnell, my colleague, has already given some introductory points, but I still would like to give David a lot of compliments, because it was early April that David had this initial initiative of a relatively small organization of professionals coming together and working towards collaborative research, sharing of knowledge. But in just less than 4 months, this organization has grown into the involvement of representatives from I think over 50 countries, in total 63 members. And the other important achievements are a strengthening of our collaborations with the International Association for Suicide Prevention, International Academy for Suicide Research, the AFSP, and importantly also with the Division of Mental Health and Substance Abuse in WHO. As David also mentioned, we're very keen to have the involvement of further partners. And our initial focus in April and May was very much to get representatives on board from countries who were most severely affected by the COVID-19 pandemic. However, whilst the end of the COVID-19 is still not in sight, we would very much encourage also a proactive approach of national governments, relevant stakeholders. So in fact, we're very keen to still get as many countries on board as possible. During April and May, the ICSPRC established a partnership with the IASP, which also has resulted in this webinar today, but in many other resources. So IASP has established a COVID-19 resource center. And one of the important resources is a list of growing a number of studies globally, particularly focusing on suicide, self-harm, and related mental health issues during COVID-19. And I would like to use this opportunity to also welcome you to look up the list and see if you could make any contribution to listing your research that may be relevant. There's 2 important objectives of sharing this information is to strengthen and reinforce collaboration in the relevant research in this area globally, but also to avoid duplication of research. In addition, IASP and the ICSPRC have put huge efforts in rapid dissemination of new publications, important evidence briefs, which most people here also on the webinar could probably use in terms of informing government representatives and also relevant stakeholders. So the webinar today is the first of a series of webinars that's going to happen, and already on the 12th of August, there's another webinar which will focus particularly on the more retrospective evidence, historical evidence of the impact of epidemics, pandemics on suicide. In September, Keith Horton will be chairing a webinar which will focus on first primary data on suicide based on or coming from real-time suicide mortality surveillance systems during the time of COVID-19. And I will be involved in a webinar in October, where hopefully we will get reports from a mix of countries and also very strongly reports from low and middle income countries in terms of the impact of COVID-19 on suicide and self-harm, but also interventions and possible evaluations that they have been able to put in place. So one of the aspects and one of the objectives of these organizations, which is already going really well, is the rapid sharing of relevant resources, briefings, publications at a global level, but also to inform people globally about relevant routinely available data that could be of particular importance now during and also after COVID-19. We also members pre-publication research data, and we're, as Keith already alluded to, we're progressing with the establishment of a global resource, a global register, where we can share information coming from real-time suicide mortality data. Initially, this will be a small number of countries, but we also hope that this can work as an incentive for other countries to put the real-time suicide mortality systems in place. As you see, we already contributed to an important UN policy brief. It was the first UN policy brief on the need for action on mental health, and suicide, self-harm prevention was an important aspect there as well. And I'm also very pleased to give you already some examples of countries that have very seriously taken on board the priorities that we laid out in the first consensus statement that was published in April. It was published in May, but prepared in April, so the Lancet Psychiatry consensus statement. So governments in Scotland and Ireland have already included the list of key priorities for suicide prevention in their updated national suicide prevention strategy to address impacts short-term and long-term of COVID-19. So I very much look forward to engage with many of you over the coming time and during the forthcoming webinars. And last but not least, an important, not so easy question for you on the poll. So do we have sufficient knowledge of risk factors during the pandemic to model its impact on suicide? Do we have the... Yep, this was along my expectations. So 62% indicates no, we don't have sufficient knowledge, particularly on risk factors relating to impacts on suicide. Yes, 13% don't know, 25%. But looking at the 62%, then I think the important resource represented by the editorial that will be launched today is definitely feeding into the needs and requirements to address knowledge gaps, at least amongst the 2/3 of the people on the poll, and possibly also the 25%. Again, in terms of the editorial, the specific areas where we say there's clearly a knowledge gap in terms of research, real-time information, primary data in relation to specific topics. In the ICSPRC, we very much hope that we will be able to collaborate efficiently and rapidly with many people across the globe, and particularly also to establish collaborative links between high income, middle income and low income countries. And I'm very pleased to say that in very short space of time, we have been able to make contacts with countries where we didn't really have initiatives or collaborative initiatives before, such as Ecuador, some areas in the Russian Federation, and also other areas in the African region. So I hope we will be able to move on and hopefully positive collaborations in the near future. So thank you very much.
Thank you very much, Ella. That was fantastic. It's certainly, I'm sure, got me thinking, and I knew what was going to be in your slides, so I'm sure it got the rest of the audience thinking too. So what I might do now is invite all the speakers to unmute themselves and turn their vision back on so we can see everybody. And we had some questions come in before we went live tonight, and we also have had some questions come in during the course of the evening or the day, the session. And so I've been trying to sort of aggregate the questions into kind of themes. And what I thought I might do, because we've got 13 minutes left, what I thought I might do to start with is ask each of the panelists a question, rather than throwing out a question and getting everyone to say what they think about it. So I've carefully selected a question for each of you, and I'll just go in the order in which you spoke. So the first question is for you, David. So there's a lot of interest in unemployment and the relationship between unemployment, predicted unemployment, and potential increases in suicide. So I'd be interested to know what you think about the forecasts of excess suicide, and particularly the forecasts that are based on the fact that unemployment is likely to rise.
Thanks, Jane. Really important question. And I think one of my biggest concerns with the pandemic is its impact on the economy in the longer term, and the very well characterized association between economic recession and suicide rates. We know, roughly speaking, from modeling studies in countries around the world, that for every 1% rise in unemployment rates, suicide rates go up by 1%. Of course, there'll be huge differences between the way countries have responded to the pandemic and the physical distancing measures put in place and the kind of economic supports they've put in place to offset the impacts of job losses and job uncertainties on suicide rates. And so this is one particular area, I think, where the collaboration and looking between countries at their different kind of mitigation measures will be helpful. But in the round, if unemployment rates go up and people don't receive adequate supports, that's likely to lead to a rise in suicide rates, and that's likely to be a longer-term phenomenon, I think.
Thank you, David. All right. So my next question is for you, Thomas. So I thought this was a really interesting question, and maybe it's a bit of a tricky one. So maybe it's not quite fair to ask you, but see how you go. So the question is, do you think if there is an increase in suicides alongside the pandemic, it will be taken seriously by authorities, or will they be focusing all of their efforts on preventing deaths due to COVID-19 itself? How do you think suicide kind of rates in there?
Mm-hmm. Mhm. Well, I think that's a very important question. That's actually one of the reasons why we have this collaboration, because the impact on suicide, if there is any, we've heard, we just don't know at this point, but if there is any, it might not occur at the same time as the impact on infections, which means that the peak, if there is a peak at all in suicides, the peak might occur later on as compared to the peak in infections. Now that's a real challenge, also because it makes it so important to have suicide prevention as a topic from early on, from the very beginning on. And that's why we are having this, also this collaboration early on, in order to ensure that suicide prevention is better represented in the overall emergency response, not only later on if all of the measures related to the more somatic areas or the infections are taken back, but it's still important to have those support systems for people who are suicidal. So that's certainly part of it. And there's certainly much more to say now. And it would be interesting to see how this what the experiences are in different countries. But here in Middle Europe, there is some focus on suicide prevention at this point. In fact, there have even been in my country here in Austria a few things that we would like to keep after the pandemic. For example, for the very first time, there is some social insurance for a greater number of people needing psychotherapy with Skype. That has been a fight, a discussion for many, many years, and now with COVID-19 it has been possible. That's certainly very different across the globe, but of course there are a lot of issues we have to face, and this collaboration is certainly part of the effort to have suicide prevention included in the emergency response already now, in order to have it established and present at the stage where suicides might rise.
Thank you, Thomas. That's a very good answer. So, Keith, I have a question for you. So there are quite a lot of questions about something you talked a bit about, which was risk factors, population risk factors for suicide in the context of the pandemic. But there were also questions about protective factors. And one of them in particular was whether anyone could comment on best practice in building resilience as a protective factor during lockdown, or during lockdown and beyond, I guess. So I don't know if you have any comments on resilience in particular or protective factors more generally.
Well, I mean, that's extremely important, but also pretty challenging to answer. I mean, I think one of the aspects, particularly of the early phase of the pandemic, that's been commented on has been the way social cohesion and mutual support within society may have increased as a result of the pandemic. Although of course that may differ very much between people who are living alone and people who are living in family or other groups. But I think certainly, I mean, in our country, there's been a lot of reaching out to vulnerable people in a way that's been really quite admirable, and that may well help protect vulnerable people, and people who are not just vulnerable physically, but psychologically, that may help protect them from ending up in a suicidal crisis or a suicidal act. So I think that's one aspect. One thought I've had while we've been speaking has been about the whole question of personal safety planning, and whether that's something that might be promoted by governments or other agencies. I was also thinking, when Thomas was responding, about the fact that where countries already have well-established national suicide prevention agencies or groups, and I'm thinking here particularly of government supported groups, then I think that puts countries in a relatively strong position in providing a response to preventing suicide. And of course, that may be an agency for helping promote personal safety planning practices, which might help mitigate the potential effects of the pandemic on suicidal behavior. This is just one or two thoughts. I mean, I'm sure there's the audience and others will have and other speakers will have other thoughts on this.
They're good thoughts, Keith. Thank you. Now, Ella, you have no. Oh, there we are. There's Ella. So, Ella, my question for you is a more general question, and you did touch on it in some of what you said when you were talking. But there's a lot of interest in what data are out there. What empirical data do we have to tell us about whether suicides are increasing or not increasing during the pandemic?
Yeah.
And I think you're a great person to ask because you're very familiar with the data that's around.
Yeah.
I think real time data.
And it's a crucial question, because now what I think is at least going to happen now is that following COVID-19, policymakers will really now start understanding the importance of real-time suicide, but also self-harm, suicide attempt data, because they're the ones asking the questions. Do you already know? Have you seen an increase or a decrease? But in most countries, we don't have that recent data. And as far as we know, there's currently really only a small number of countries, so including Ireland, which only has one region with real-time data. There's a region in England involving Horton, and then Australia has two regions involving Queensland and also yourselves, Victoria, and New Zealand, who are definitely a little bit ahead also to the small size of the country, but they have national real-time suicide mortality data. So I'm convinced that it's going to be convincing to policymakers that even come a second wave or a third wave or any other similar phenomena that are so unprecedented, I think we now can make the case, and we should make the case. Now, the other issue, which is further complicating, it's all well and good if people now start gathering real-time suicide mortality or self-harm data. But if you don't have a baseline, you don't know, are you seeing an increase? Is it a stabilization or is it a decrease? And in working also with people in Ireland based on the National Self-Harm Registry, working in Queensland and also with yourselves, we will only really be able to say, is there an upward trend? Is there a stabilization? Is there a downward trend? If you can compare the real-time COVID-related data to 3 or 4 or 5 years before. Now, you may still then be able to resort to your retrospective data based on your national or regional offices of statistics, but you have to be very cautious that the methodology and the procedure should be similar. The other word of caution is in all those 5 areas, geographic areas where there is the real-time data, we're currently really talking about suspected suicide cases, because in most of these instances, the coronial or the forensic procedures haven't yet been completed. But it is definitely critical, I think, for us globally to make the case now, which I think we can and will be probably be more embraced by policymakers than before.
Thank you so much, Ella. So it's 1 minute to go. So I think I might hold off on asking further questions, even though there are a lot of additional questions that I'm sure people would like to ask. But do feel free to email any of us to follow up after the session. So I think where that leaves me is just to thank a few people. So first of all, I'd like to thank everyone for coming. I can see at the moment there are 212 participants on the line, so thank you all. I'd like to thank all of the members of the International COVID-19 Suicide Prevention Research Collaboration. And David shared with you the magnitude of the group. Thanks to every single one of you for your contributions to date and your ongoing contributions. I'd like to particularly thank our fantastic 4 speakers. And if we weren't on Zoom, I'd be getting everyone to applaud. And I'd like to thank Karen, who's been our interpreter in the background. Has done a fantastic job interpreting all of our garbled speeches into Portuguese. Thank you very much, Karen. And I'd like to thank IASP for partnering with us tonight, and in particular Wendy Cliff for all her technical expertise, which I know hasn't been easy. So thank you all. So we might leave it there. Join us for future webinars. Thank you.
Okay.